Welcome to Pomegranate Health from the Royal Australasian College of Physicians. I'm Mick Cavazzini, and today I'm going to give you a taste of RACP LIFT 2026. This is a series of in-person events intended to promote learning, innovation and forward thinking. The stream called Rapid Fire Clinical Updates does exactly what it says on the tin, bringing together the creme de la creme of clinical leadership and research that the college has to offer. The events don't just include fascinating seminars, but also provide an opportunity for reflective activities with peers that can go towards your Category 2 CPD. Coming up on the 1st of August in Melbourne, there will be one based around respiratory medicine, infectious diseases and critical illness. And on the 20th in Brisbane, another one themed around palliative medicine and also population health. Today's podcast was recorded at a rapid-fire event on cardiometabolic and vascular health, held in Sydney on the 31st of March. There were loads of great talks, but the one I'm sharing with you didn't rely too heavily on a data slideshow. It covers everything a generalist needs to know about recognising metabolic dysfunction-associated fatty liver disease. As MAFLD is becoming increasingly common, all physicians need to be aware of it, not just hepatologists. The seminar was presented by Professor Jacob George, Director of the Storr Liver Centre at the Westmead Institute for Medical Research. He has made an immense contribution to the understanding and management of liver disease in over 13,000 academic publications that have been cited more than 90,000 times. Professor George explains why fatty liver disease is a canary in the coal mine for metabolic health more generally. He covers diagnosis using scans and bloods, and how to use the FIB-4 index. Also, how patients can be stratified and managed for risk of more complex liver disease. Lifestyle interventions are of course critical, but there are a few promising pharmacological interventions on hand too.
So thanks very much for inviting me today. I'm going to really talk about MAFLD for the general physician or the cardiologist or the nephrologist. Why should we talk about it? Firstly, I think in the liver literature, we're really saying it shouldn't be CKM, it should be CKLM, and we just submitted a paper to Nature Endocrine Review suggesting that it should be CKLM syndromes. The second reason, I guess, is today we've got approval by the TGA for Wegovy or semaglutide 2.4 milligrams for MASH, or the inflammatory form of the disease. And the last reason is that having an end-stage liver disease is probably the most miserable way to die. And most of you cardiologists and renal physicians are making people live longer. So in the old days, we didn't get much liver disease from fatty liver because you've got 1.5 kilos of organ to play around with. Now that you're fixing their hearts and their kidneys with renal replacement therapy, all these patients are now coming, and the peak of MAFLD-related liver disease is probably going to be in the next 15 years. And so you need to know something about this. What is MAFLD? So many of you would have heard non-alcoholic fatty liver disease, or NAFLD. The new name for it in Australia that we use is MAFLD, or metabolic dysfunction-associated fatty liver disease. The big aspect about this is it's very easy to diagnose. If you've got liver steatosis, by whatever technology you want to use, CT scan, ultrasound, blood markers, whatever, and you're overweight or obese, then you've got MAFLD. If you've got diabetes and liver fat, you've got MAFLD. If you've got lean disease, so you've got a normal BMI by ethnic specific criteria and you've got steatosis, you've got MAFLD. And so it's a very simple definition, and the most important aspect, it's a positive definition. Whereas non-alcoholic fatty liver disease said you have to exclude everything else, and if you can't think of what it is, it's non-alcoholic fatty liver disease. What this means is that you can have Hep C and MAFLD, you can have Hep B and MAFLD, you can have alcohol-related disease and MAFLD, and that's really the unique strength of a very simple diagnostic term. And so you don't have to go and do a million other tests, which may be in primary care, you may have to do it. But in specialist care, you could say, this patient's got MAFLD, I need to do something about it. Okay, so how common is MAFLD? MAFLD is the fatty liver aspect of it, so you don't need a biopsy to diagnose it. And the current estimates are 30% of adults have it. By 2040 in the US, it's going to be 1 in 2. So basically, it's very, very prevalent. MASH is metabolic-associated steatohepatitis. In other words, the inflammatory form, exactly similar to atherosclerosis, for example, in your blood vessels. And the MASH prevalence is 1 in 20 of the general population. But if you look at the population with fatty liver disease, then it's about 1 in 5 of those people. The second point to remember is that when you look at patients with MAFLD, we always tend to think of MAFLD in patients who are overweight or obese. But this is looking at data from a paper we published a few years ago. But it doesn't matter from which country you look at, 1 in 5 patients with MAFLD are actually lean by ethnic-specific BMI criteria. So just because someone looks lean, and this is particularly a case in Asians who don't look like with a BMI of 35 or 40, but they've got truncal obesity and they often have fatty liver disease. And in fact, they tend to have a worse liver prognosis than people with overweight or obese disease. So I guess this brings to the question of, why are we talking about liver disease? And in many ways, when you look at metabolic disease and metabolic health, the liver is the canary in the coal mine. And so this is a great article by Sam Klein, and he suggested a definition of what does it mean to be metabolically healthy. And most clinical physicians really look at these basic criteria. I don't have type 2 diabetes, I don't have pre-diabetes, I don't have fatty liver disease or CKD, so I must be healthy. But what Sam then goes on to talk about is, well, you actually need to be metabolically healthy. You need to have a good cardiometabolic profile, which is a low TGs of less than 1.07, low HDL cholesterols, a good fasting glucose of less than 5.5. But he says that truly to be metabolically healthy, you really should have no liver fat, either by doing an MRI on the liver, or you could do a clamp test, which obviously we don't do. And so I think if all of you look around yourself and find out how many of you are truly metabolically healthy, the answer would be not many. Okay, so this is the metabolic dysfunction-associated journey that I talk to patients. The first thing that happens is we have adiposity. The next thing that happens is you get liver fat deposition. Then you get intracellular lipid. Then you begin to get beta cell dysfunction. And then the patients present with atherogenic dyslipidemia, hypertension, type 2 diabetes, and then end-stage liver disease end-stage disease with cardiovascular disease or chronic kidney disease. And that's really the trajectory. And when I talk to patients, I actually say, you've got past that, you've now got hypertension, you've got now hyperlipidemia. Are you waiting for your infarct or your extrahepatic cancer? And when you actually look at liver-related outcomes, why hasn't it got more airtime? And this is really the course from fatty liver to HCC, cirrhosis and HCC. So you can see that most liver-related deaths occur when you've got cirrhosis. So the DLCD is decompensated chronic liver disease, or HCC. And there are a few HCCs or liver cancers that you can get in the pre-cirrhotic population. But the incidence of liver cancer in pre-cirrhotic is very low. So we don't recommend screening. But as you get fatty liver disease, because it's the canary in the coal mine, what you're seeing is what most patients are going to die from with liver disease is a cardiometabolic death or an extrahepatic cancer death. So when you understand that, it's very, very important to really focus on cardiometabolic outcomes and make sure the patient gets their screening for the extrahepatic cancers. Okay, and this is really a nice study that I give in all my liver talks. This is a study published from Scandinavia in data just as only the Scandinavians could do. They looked at 270,000 Swedish people with type 2 diabetes, and essentially they looked at whether these 5 cardiovascular risk factors at baseline was above or below. And then what they did was they looked at overall risk. And if you can see in the control population, everything is 1. But if you had no cardiovascular risk factors, so HbA1c was less than 7, low LDL, non-smoker, no albuminuria, blood pressure below that number, you have no increased risk of excess mortality. Essentially saying that the most important thing from a liver perspective is really treating to target. because that's what's actually going to kill the patients. Except in the future, I guess, with all your treatment for kidney and cardiac disease, we will be getting patients with chronic liver disease. So this is the MAFLD management guidelines that we put forward last year, and it's published in the MJA and it's on our website. If you can see that half of all of that work is assessing and managing cardiometabolic risk as per the diabetes, obesity, cardiovascular risk factor calculations. Okay, that should be done on every patient. And then we think that you should be looking for liver disease because you want to try and capture the patients that might benefit from treatment, particularly now that we've got drugs that may be impacting on the disease. And so what we suggest is that you can do a FIB-4 index, and it's a very simple test with age, AST, ALT, and platelets. And so as you would expect, as you get older, you get more duration of liver disease. Your platelets drop when you've got more severe liver disease. And at least in DHM, Douglas Handley Moyer, you can just write FIB-4 on your pathology request form. They'll do it for you. You don't have to use an online calculator. And we're very close to getting the RACP to send a letter to all private and public specialties and pathology labs to say, please include a FIB-4 calculator. And then we have a very simple algorithm. If your FIB-4 is less than 1.3, manage them in primary care. If it's more than 2.7, send them to a specialist. If it's in between one of them, between 1.3 and 2.7, then you can try and refer the patient for a FibroScan or a second-line test. And so the reason why we use that, because the FIB-4 score doesn't cost anything, the laboratory can easily do it for you. If the FIB-4 is less than 1.3, it excludes advanced fibrosis. Patients can be managed in primary care. If it's more than 2.7, you've got a specificity of 91%, but not a great positive predictive value. But those are the patients that need to be referred to a hepatologist. And this is some longitudinal data done in the US. If you have a persistently low FIB-4, your risk of a liver death is very low. If you've got a number greater than 2.7, your hazards ratio is increased 20-fold, and the risk of a liver death is about 10% over that period of about 20 years. So there are some drugs that are being tried. So it's been a very hot area for clinical trials. All the GLP-1 based drugs, resmetirom and FGF21 analogues are in clinical trials. Semaglutide was approved by the TGA today. Resmetirom it's a thyroid hormone selective liver-directed therapy. It's approved in the US, costs $50,000 a year, and it's very unlikely to get approved in Australia, though the CEO of the resmetirom company actually is an Australian, and so he does want to get it approved, but I don't fancy the federal government approving it. So this is the data from the Essence trial. If you thought renal was hard to get patients into, this is only 800 patients. And the reason we can't get people in is you need a biopsy.
I'm just going to step in here to give you some details you're missing without the slideshow. Essence was a trial described in the New England Journal in 2025 with the title Phase 3 Trial of Semaglutide in Metabolic Dysfunction-Associated Steatohepatitis. The headline finding was resolution of steatohepatitis with no worsening of liver fibrosis. This occurred in 63% of patients taking semaglutide, compared to 34% of patients in the placebo arm. When looking at improvement of liver fibrosis, the difference was 37% to 22%. Another trial published a year prior, also in the NEJM, showed very similar results for resmetirom. This is a first-in-class drug that is an analogue of the thyroid hormone triiodothyronine, stimulating its receptor and increasing lipid metabolism and beta oxidation. This reduces not just hepatic fat, but also inflammation and fibrosis. In the findings from this phase 3 trial, NASH was resolved in 3 times as many patients receiving the drug as compared to placebo. For the endpoint of improvement in fibrosis by more than one stage, there were twice as many responders in the resmetirom group, and reductions in LDL cholesterol of 16%. Professor George also quickly showed some similar findings from phase 2 trials of an experimental drug called efruxifermin. It's one of several analogues of the human fibroblast growth factor, FGF21. These appear to inhibit activation of the hepatic stellate cells that cause fibrosis, and may indirectly reduce liver fat and lipotoxicity.
So MASH resolution compared to placebo, you can see is very effective. And fibrosis improvement also, there's a delta of about 20%. The phase 3 trials have actually started, and they're also now doing trials in cirrhosis. So how do we think patients should be managed? And I think it behoves all physicians really to think about doing this. Get your laboratory to do a FIB4 test. If you're interested enough to do an albumin-creatinine ratio, do a FIB4. If it's less than 1.3, they can be managed in primary care. More than 2.7, you have to refer in between 1.3 and 2.7, which is about 20% of a community cohort. Then you need to think about a second-line test. So what is the MAFLD treatment in 2026? It is the canary in the coal mine for metabolic health. GLP-1 based therapies have profound systemic effects on metabolic dysfunction, as we've heard throughout today, and MAFLD is a small part of it. And as you know, incretins have now been recommended by WHO, but costs and supply chain issues are a problem. I note that the patent in India for GLP-1 agonist finished about 2 weeks ago, and the day after there were 40 generics. So that's actually available. And so semaglutide is approved in Australia, and we've got more phase 3 trials on the way. So I think in the next 5 years, we'll have 2 or 3 medications for this indication.
One feature of the rapid-fire clinical update events is the case vignettes put to the audience with opportunity for discussion. I'll just read out in all its detail the slide put up by Professor George. Jessica is a 46-year-old female with type 2 diabetes and hypertension, which were both diagnosed 5 years ago. She takes metformin 1 gram daily and telmisartan 40 milligrams daily. She consumes no alcohol. Her BMI is 31 kilograms per metre squared, and blood pressure on the day is 145/85. Her most recent HbA1c was 7.4%. Blood tests show a mild elevation of GGT and ALP at 125 and 30 units per litre respectively. ALT is 55 units per litre, AST 40 units per litre. She has a platelet count of 175 by 10 to the 9 per litre. Bilirubin is 10 micromole per litre, and her coagulation profile is normal. Referral for elastography with FibroScan is available, which reveals a median liver stiffness of 6.1 kilopascals, normally below 7, with a CAP of 310, normal scores below 260. CAP is the controlled attenuation parameter, which comes out of measurements for steatosis by shear wave elastography. And the question is, what would be the next best step in management? A. Referral to a clinician with expertise in liver disease. B. Optimise blood pressure to less than 140/90 and target an HbA1c of less than 7%. Discuss strategies for weight loss and assess for other metabolic risk factors. C. Repeat non-invasive testing for fibrosis in 12 months. Or D. Reassure her that her blood pressure and HbA1c are within an acceptable range. Those options again: A. Refer to a hepatologist. B. Optimise blood pressure and diabolic control. C. Repeat non-invasive testing for fibrosis in 12 months. Or D. Rest easy that blood pressure and glycated hemoglobin are within an acceptable range.
So HbA1c is 7.4, LFT is mildly abnormal, platelets, bilirubin, coags normal, FibroScan is 6.1. What would you do? The correct answer is B. Most of these patients, it's about optimizing metabolic health. It's that small proportion that's got a FibroScan that's high or a FIB4 that's high that you need to refer to a liver specialist. And I think all the speakers have emphasized the importance of really treating to target. There's even been studies from China that says if your blood pressure is 120/80 versus 130/80, and you lower the blood pressure to 120/80, you do better. And similarly, all the PCSK9 kids, they have half the risk of cardiovascular disease. So very profound impact of cardiometabolic risk reduction for survival. Thank you.
Many thanks to Professor Jacob George for sharing his time and immense expertise. At the website racp.edu.au/podcast, I've included a transcript of this talk with relevant citations embedded to help you dig deeper. And at the Medflix video library within eLearning, you can watch the full video and slides, along with all the other great talks from RACP LIFT. Professor David Sullivan and Dr. Jay Ramanathan also need to be thanked for curating the program for this rapid-fire clinical update on cardiometabolic and vascular health. And a huge shout out to the RACP events team who worked so hard to pull it all together. You can see what other clinical themes are coming up from the website racp.edu.au/RACP-LIFT-2026. And also learn more about the Career Triage Conference and an in-depth conversations format scheduled towards the end of the year. Remember that while podcasts and lectures get you hours towards CPD Category 1, it's only by interacting with peers that you can reflect and get feedback for Category 2 credit. If you've got ideas for future podcasts, please get in touch with me via the email address podcast@racp.edu.au. And make sure to subscribe so you don't miss an episode of Pomegranate Health. A smartphone app like Apple Podcasts, Spotify, or Castbox is easiest, but you can also sign up to an email list from our website. And do leave a review or share the podcast with a friend to help us spread the word about RACP learning resources. This podcast was produced on the lands of the Gadigal clan of the Eora Nation. The Royal Australasian College of Physicians is committed to equitable healthcare for all First Nations people. I'm Mick Cavazzini. Thanks for listening.